Shawn needs no introduction, so I'm not going to introduce him. I'm just going to hand him the microphone. He's going to talk about something that we've been talking about, reusable networks.
Thanks, David. I think when we started this, or when I got involved in this 18 months ago, I certainly had two goals. One was the goal of the collaborative, which I think we're all celebrating at the moment. The second was, though, this idea of what legacy might be left in place afterwards. Not an organized, funded, facilitated legacy, but a natural connection network that might be left behind, what it might look like, and what it might be able to achieve in the future. And so this is what we're talking about, something that's left, now we've had this little sandbox, left in place for us now to utilize. Dave's touched on something that one of the benefits I've seen already is the non-collab work that we do around this. So now already it's very clear that we have solved a number of issues, and like Dave says, when we're talking in the middle of the night, you know who you're talking to. So I think it's established that, and we have this firm. I don't think this is the beginning of a network. I think the network's here. And like Janice was saying, although learning session 1 might have been daunting for you with all the information that came from the floor out, you now are the owners of probably the real collaborative knowledge in New Zealand. And people will be coming to you, and it'll be a matter of picking which jobs you want to take on with your knowledge, because they're going to approach you, and they're going to want you to be involved in quality initiatives, I think, over the whole spectrum of healthcare. So I thought I'd have three rules here about surviving social networks, based on last night. The first one is that you've got to take advice carefully. After last night. This was written after, fish and chips at 3 in the morning. This came to. I think we're also at a very exciting time here. So it's not just that we've come to the end of a collaborative and it's done very well, but this is a tipping point, I think, in healthcare. One is because we're in New Zealand. New Zealand it's got some features in line with some other countries that I think are very important. It's a developed country, so we've got developed healthcare, we've got connectivity, we've got a reasonable primary healthcare system and healthcare networks. More importantly, though, we're only moderate in size, 4 or 5 million people. So this puts us along other countries like Scotland and Norway, and so what you have is you have the flexibility of a moderately sized country, but with an established network. And I think what this means is that you can take change rapidly through a system and affect change in 18 months like this. I think if we were trying to achieve this in the NHS or across 10 states in the US, it just wouldn't go like it's gone. And so if you look at countries that are into this collaboration practice, like Scotland now, they have well-established systems which have fantastic results. And it doesn't involve the work and the funding and the human resource input that people thought it would in the beginning. So you're in one of these situations here that the next change will occur more rapidly, I'm sure, more rapidly than this. The second is this little R word. I'm not going to talk about rationing, but the healthcare in the US now is driving this discussion on where will medicine go next. It's not going to go to more heparin-bonded circuits and more technical intensive care beds. It's going to go towards, I think, patient-focused care that is efficient and effective. It's going to be systems-based. It's going to be a different system to the one that's been growing, especially in the US, up until this date. And if you're going to start looking at systems like this, you're going to start looking at people and the way they practice. And I think networks are going to be the basis of this efficiency and this focus on patient care and patient safety. So these two facts combined, the fact that we're in a country that I think is nimble and is a platform that we can manipulate. And secondly, the fact that people are now asking just what we get from our healthcare and how far can our little health dollar go. I think these two cross to put us in a very exciting position. Just for example, I mentioned this triple aim. I think historically people have thought that you can't have quality without cash, and you can't have efficiency in management without upsetting the medical side of things. And I don't think that's the case anymore. I think we realize that if you put the patient in the middle of the triangle and you focus on efficiency or quality outcomes or fiscal issues, you optimize one, you'll often optimize the others. Some of the work I've done this year in my intensive care unit has been purely around funding and budgets. But that's also affected care because it's affected practice. We've reduced variation in the way we prescribe, in the way we allow registrars to prescribe, the way we order tests, all with a view to reducing money and making things more efficient. But what we've come out with is probably also a safer system at the same time. And so I think that what we'll find is these aims, whether they're money-orientated, efficiency-orientated, safety-orientated, are all going to be achievable by focusing on the patient. So you do own the new black, I think, here, and you guys are the resource that will that'll be sought out. It's not a matter of thinking, how am I going to initiate the next change? It's going to come and get you. Already the HQSC and others are establishing connections with people, and there are, if not projects, committees and discussion groups forming on what should we do next, or how can we improve these programs that are running currently. And they're going to come to you and build on your knowledge. So where are we at the moment then with this collaborative? We've come to an end of a process where we've achieved the content. We've reduced CLABs. We've now got processes in place to monitor that. We've come to, I suppose, the end of the 18 months, and people are wondering what structure's left. I think it's safe to say that between now and probably December, there's going to be ongoing data collection and ongoing funding, and this is not just going to stop straight away. But what it also has made me think about is where do we sit? We're not under a government agency or a particular non-government agency. We're not collegial. It's not like this is an intensive care college initiative or an IPC-owned initiative. We sort of sit between these. We sit between HQSC, between Kawatea, between the Ministry of Health. We sit in our little silos, whether it's in a medical silo or an IPC silo or quality improvement or DHB operational silo. So we're stretched between all of these, and I think that this is scary in some respects, but also allows us to be very powerful in others. Clearly there's a lot of us involved, and I think a collaborative is more than just many people or many nodes. People talk about this multi-agent system where it's a relatively rigid system, there's some linkages between us, and when I talk to people about a collaborative, they don't understand the word users are now, and I think what they mean is we're doing it sort of in a friendly way. You know, I talk to surgeons and they say, oh, you collaborated on this. The thing is with multi-agent systems, they're not as resilient as the system I think we've got here. If you tap a multi-agent system often, or you remove one of the leaders, or you take away one of the lines of communication, the links between a node, the system falls over. I don't think it shows the resilience or the robustness that we were talking about yesterday in a complex system. So I think we're more than that. I think although we come from very similar units or microstructures, all of us, we're all very similar in what we do, we've evolved into a system that is quite complex. And when I say evolved, I mean it's not just the training that you've got, it's not just the experience you've got, it's not just the friendships that you've got, but we all bring different skills to the table. Between those groups that I've just mentioned in this room, we could achieve almost anything. I mean, we could work out over the next year how to reduce patient falls, or to improve the air retrieval service in this country, or that wouldn't be hard given the skill in this room. And I think this is why. This is the process involved in evolution. You know, I've tried to say this. We're complex. We've organized this ourselves at each level, whether it's at the unit level, the hospital level, the regional level, the national level. We didn't roll out a chart that said this is how you have to have your structure. You went to your environment and you organized it yourself. And I think that's what makes it resilient. A lot of stuff has emerged from this. So we've got one node linking to another, and it's become a more than 1 + 1 = 2. We've had original research published by Dave and others that show the impact of CLAB on hand hygiene program. We've had excellent audit data in America now with their collaboratives, including the CLAB collaboratives. People always question the validity of the data, and the accuracy of the measurements and so on. And not only have we come to the end of just our first collaborative, but we've also got data to show how valid and how accurate it is already. Strong lines of communication. I'm glad to see that the telemedicine is working here. You know, 12 years ago, I think when I was down in Dunedin, I worked with a guy from the US, And he was very used to this. In fact, he'd opened up one of the world's first virtual ICUs, VisiQ in Boston. So at night, 5 or 6 units would hand over their patients over the telephone. So he'd be running like 100 beds. There'd be registrars in these units, and he had these complex monitors, and he had this big book of lawyer-calculated management schemes for medicine, and he would advise overnight on these bed spaces. So I think the leverage that you can get out of a system in a country like New Zealand by using good AV, and I don't mean just what we've got on the hospital line where you can see somebody's lips moving, but you can't hear what they're saying, and you've got to dial in at the same times. Something really effective where it's a face-to-face meeting is going to be very powerful for this country. And I want to stress this point, that we all come to this room with primary and secondary features. So although I'm an intensivist, it doesn't mean that with my skill base, my experience now, I've got to do something in intensive care in my next project. I probably will, because it's my back garden, and it will probably be something to do with hospital infection or IPC, but it doesn't have to be. And I'm now a bit more comfortable with going to somebody who's trying to cut 20,000 bed days off their hospital year, or looking at patient falls. And I think we all now have a secondary role, and that'll be sorted out. So what are we going to do now with this at the end of the collaborative? We're going through a point of transition. I think there's going to be ongoing support for this, and I think that it's now part of your practice. It's not like I can put this hat down, the collaborative hat for collab, and I'm going to take on another one. This is now part of your practice, and I think we've normalized it in hospitals. The content, therefore, will continue, but we're going to have to prepare to use the process. Like Dave said, nobody's going to come down and say the next one will be X, and then after that there'll be another, this one. And if we come up with a valid set of ideas, people will listen to what we're going to say. If you look at how CLAB started in this country, it didn't start with the HQSC saying this has been so important elsewhere in the world that we've got to work on this. It started with, I think, to be honest, Middlemore's interest in driving this. People started to look at the model, connections rippled around, and we saw that this was a valid problem in this country. It had been solved elsewhere. We could solve it here. And before you know it, it became a focus that we then got told, well, get on with it and solve it. And so in this room is probably the responsibility for working out the next project. And it's got to be done in a way, I think, that has some credibility and some teamwork around it, and we'll be listened to, and then we'll own that. So everybody else has had a breakout session. I'm going to have one. I want 5 minutes to talk about if this is the way we're going to go forward, right? You've got your secondary process hat on, you own the knowledge, and you are responsible for deciding just what we think we're going to do in the next couple of years. What do you want this to look like, this sort of network? You know, originally I had very concrete ideas about this network. You know, should it be owned by somebody or an organization? Should it be facilitated or coordinated by somebody? I'm not so sure it should be now, but I'd value your ideas on what might help this string of connections we've got survive. Just for 5 minutes. This is quite interesting. I think there's a lot of talk here, and it's immediately just exploded into all the things we want to talk about how we go forward from here, where the funding will go, what the next job is. But something Mo just brought up here is very interesting. One of my interests here now is where does the patient sit in this collaborative? You know, everybody's talking about patient-centered care, but how much is the patient responsible for, and also how much pushback do we allow the patient to have on our practice? How transparent do we want to be? At one of the tables we were talking about data safety and how open are we going to be with results. I think the patient is going to become fundamental to what we're talking about in collaborative healthcare. Mo brings up a good point. We're talking about telemedicine here, doctor to doctor or hospital to hospital, but what about patient to hospital with patients that are high users that are in the region, like dialysis patients and so on? I think that's a very reasonable point, for very efficient there. You can have patients, certainly in New Zealand where we're spread out regionally, or have patients that are routinely otherwise coming to hospital by long transport. I think there a massive potential for telemedicine. All these good ideas, you see, this is what it's about. So, there's a few ideas then. If I go back to my questions, does anybody want to just talk about then, or make a comment on ownership? Is what we're doing here something that should be owned, or? Cheryl?
The data we collect, if it's not owned by somebody, whether it sits within the Health Quality and Safety Commission
If we stop reporting this data to somebody, where someone has that overview, yes, it is a number, but it still makes us accountable for what we're doing, and it will keep it going because we need to report that number, and I think that needs to be owned. Where, I'm not sure. But just as far as keeping it going, we think the information needs to be owned. We still need to put it somewhere. All of us need to put it somewhere together.
And that raises a good point. Although we maybe don't need a badge to say that we belong to this, there's certainly aspects of practice that we're going to want taken care of in this group, whether it's measurement or recording or communication. And I think we're seeing this develop. I mean, Debbie and the HQSC would probably be more able to talk about this. Would you like to say anything at this stage, or?
About the ownership of the...
Well, about what the thoughts. Well, about the thoughts of how what we've got here, which is quite an organic process in place, might be facilitated by, in the future, by things like a database or a communication structure, or just briefly. That would be fine. That would be great.
Yeah, my experience and view of collaboratives are that you do need some kind of coordination, to keep them going. Somebody has to kind of take responsibility to say, in international ones, that might be one country that says, yeah, we'll do it for all of the rest, or it's one agency within New Zealand, and I think that needs to be something that we think about as a commission. So just having the responsibility for kind of organising the webinars, organising the kind of virtual meetings, organising, and kind of creating an environment where people can share what's going on and share information, what they're doing, and keeping the thing kind of alive. And of course that is about the data, and of course it does have to be collected nationally somewhere safely, and yes, we are thinking about that and how that should be done. Yep.
Remember that we're all going to naturally, I think, keep energy in the system. For example, the APAC conference coming up, there'll be slices of us slices of us at that meeting, and we'll be maintaining the systems that we're talking about now. For those of you who are interested, the Scottish systems, the Scottish Patient Safety System, SPSS, if you search that, you can get an example of a very developed quality network. The NHS, although it's a behemoth, I think, as Suzanne displayed yesterday, has a lot of good resource, but a totally different scale to what we're doing. So my last slide now, for the time, is how do we go about leaving this room and thinking we're still part of a group? And I think it's about a frame of mind. You're all going to nominate yourself for committees, or put yourself in projects, or go to a conference, or engage when somebody phones you up. So I think it's going to be a natural process. It doesn't have to be owned. I think a distributed network is what we've been talking about here, and I think that's how it should remain. I think you'll find that the facilitation will be there. As projects pop up, people will support it with databases and communication structures. Academia is growing in this department, in this centre and in other centres. People aren't just studying collab, they're studying about collaboratives and how they work and how big they should be and what dose they should be and how do you measure the output from a collaborative. And this will, I think, help bind us together. We normalise what we've learned in our silos. So when I go and talk to my registrars every day about intensive care medicine, I also bring in quality and I also bring in collab prevention. And so I think what we'll do is take it back to our primary silos as well. This is something now that we'll be doing every day via our DHB, our professional bodies, the collegial relationships we've got, and steered or assisted, facilitated by groups such as the HQSC or Karate. And I think that's where we'll be going. Okay, that's all. Thanks.
There are a lot of questions that Shawn's raised, and there's been a lot of great discussion. I think that we're going to need to harvest the ideas from that discussion in I think, a bit more of a systematic way. We do want to come back with some kind of proposal to keep this network alive, and we haven't got the answer for you right now, how we're going to do that. But I think that let's talk about that as the day goes by. And by the end of the day, let's think about how we might make that happen, okay?